Care Services and past chief of staff. He's the professor in the Department of Orthopedics at the University of Minnesota. And Dr. Novacheck's research has focused primarily on outcome studies of management and gait disorders in individuals with cerebral palsy and in the improvement and development of the motion analysis testing methods. He's the immediate past president of the American Academy for Cerebral Palsy and Developmental Medicine. Dr. Novacheck sees patients in St. Paul and Maple Grove. And I welcome Dr. Novacheck to the conference, and he's going to be presenting on an orthopedic eye on gait abnormalities. Go ahead.
Well, thanks, everybody. I have to give a little apology here. This is orthopedic surgery time. You've joined at 7 o'clock. This is a common starting time for us. So this is the usual time for me to be very active. So I apologize in advance if I go a little fast. I've got a lot of material. And the other thing is I get very excited about what I do. So I want to share a lot of information. So hold on, and we're going to get through this together. So we're going to talk mainly about orthopedic care, but cerebral palsy, by definition, is a motor disability. It's a problem with movement and posture. It is non-progressive and presents early. There are many different etiologies, and so our patients are not all the same. The issue is that because of the neurological problem, there are difficulties with normal development. So children don't play and run at the normal times in the normal ways. And as a result, they end up with secondary musculoskeletal deformities, such as muscle contractures. And because of the abnormal skeletal forces, they have bone and joint deformity. And that's where we come in as orthopedic surgeons. In the past, there was an awful lot of focus on tendon lengthening surgery, and those treatments we found were ineffective. So I'm going to talk about newish developments, such as new methods for physical therapy. Different types of orthoses are possible. I will focus a little bit on gait analysis, and then the fact that we've moved towards a concept of doing multiple procedures under one anesthetic. That's called a CEMALS, single event multi-level surgery. And Andrea's going to talk after I am done about tone management, so I'm really going to avoid that, but it is really important that our paradigm for multidisciplinary care includes not only orthopedic management, but also tone management to the best that we can possibly do. And that the fact is that our orthopedic approach, partly because of the focus on tone management, has allowed us to move away from the muscle and tendon lengthening surgery more towards lever arm deformity correction. So it's bone and joint realignment surgery, and I will focus a lot on that. And the fact that this is all done in the milieu of a multidisciplinary team that is hopefully well organized. And there are many different new classifications. I'll spend just a little bit of time talking about that. Muscle and cerebral palsy is significantly affected. Of course, CP is a neuropathic condition, but it has these secondary effects on muscle growth. And there are certain muscles that are more involved than others. Bones then also are abnormally affected because of the abnormal muscle forces and also the ground reaction forces. And in the end, this leads to a failure of normal modeling of the skeleton. So things like femoral aneurysm that children are born with don't remodel. So we call that persistent fetal alignment. And then there's also abnormal forward modeling. So children are born with an internal tibial alignment, and they oftentimes develop an external tibial malalignment because of the abnormal skeletal forces. Spend just a little bit of time talking about cerebral palsy classification. You can talk about different classifications based on tone type or geography. And all these patients are affected in different ways. And because of that, their treatments are different. And we just aren't going to have enough time this morning to get into the nuances of each of these. The GMFM is a test that's performed by a trained physical therapist that includes 66 items, and it takes about an hour to do. But based on the GMFM, there's been the development of the scale, the 5-point ordinal scale called the Gross Motor Function Classification System. The Gross Motor Function Classification System has 5 levels. Level 1 is the highest level of function, going to level 5, the lowest. And by age, you can see that children all start at the same point, And then as they go through these early years of development, and we have a talk on early diagnosis and intervention. So it's really important at these early stages that we help to understand where children are and make diagnoses and classifications. But as they go through these first 3 or 4 years, they really stratify according to these different levels of neuropathic involvement. The GMFCS1 patient with cerebral palsy is able to get around on uneven surfaces. They can walk and run. They can go up and down stairs without using a hand railing. The next level of involvement is having maybe not running as much, but having some difficulty on uneven ground, but still walking independently without an assisted device. But using a hand railing is one of the key features to go up the stairs, is a key differentiation from GMFCS1. GMFCS3 individuals walk with assistive devices and sometimes use a wheelchair for longer distances. GMFCS4 is more dependent on an assisted device for all ambulation, and oftentimes is only shorter distance ambulation in the home. And GMFCS5 individuals are using a wheelchair for their mobility. These different categories are very important because they are predictive of many different things. And one of those things is hip displacement. So here's a graph of GMFCS 1 through 5 showing the incidence of hip dysplasia being no different from the general population for individuals who are at GMFCS 1 versus being extremely likely for people with GMFCS 4 and 5 involvement. And so hip displacement is a significant problem for the more severe involvement levels of cerebral palsy. Because of these complexities, we do use gait analysis to help us understand what's going on because there are primary problems with these neuropathic issues, there are secondary problems with the bone and joint malalignments, and then it even gets more complicated than that with compensation movement patterns. So using gait analysis is helpful to cipher through all of these different complexities. When we think about ambulation, it's important to think of muscles and the ground reaction forces. They are the forces that provide the joint moments that are responsible for motion. But those muscle forces have to function on a rigid lever arm. So our lever arms are skeletal structures, the femur, the tibia, the foot, for example. And with the activity of the muscles working on these lever arms, they work around the joints to create moments that lead to motion. We have to remember that these muscle moments are important not only for propulsion, but also for joint stabilization. And when I say moment, I think we all understand this analogy of someone of a larger mass sitting at a shorter distance on a teeter-totter relative to a smaller person or individual sitting at a longer distance, so that these two moments, the larger mass times the shorter distance, can be balanced across this fulcrum. So if I say moment, then I'm talking about this force times the lever arm. In this sort of a diagram. The forces, again, are created by the muscles, and they're very important anti-gravity muscles because we know that those ground reaction forces, gravity are always trying to pull us down to the ground. So to maintain an upright posture and stance, we need to use these anti-gravity muscles. Let's talk about the pathology further in cerebral palsy. I've already mentioned briefly that there are these primary neuropathic effects. There are the secondary musculoskeletal deformities that develop with growth and development. And then there are compensations. These are the coping responses that individuals use commonly to improve their level of function. And we do use the gait analysis laboratory to help us understand the biomechanics so we can do a better job of diagnosis and treatment planning. And then they come back for a follow-up visit after significant interventions so that we can assess the outcome. And because we've done this thousands and thousands of times over 35 years since the Gait Lab opened, we're able to better understand biomechanics. So we're doing this constant learning by studying our patients and understanding what's working and what's not. Now, my focus today is going to be on orthopedic surgery, but again, this has to fit into the milieu of everything else that's going on for individuals with CP. So that includes their therapies, their orthotics, exercise and physical activity, and other things like tone management. And all of this needs to be done with an eye towards function and an eye towards setting goals. And what I'm going to be talking about here mainly today is when people want to walk or walk better or walk without assisted devices or walk further, it's all about setting those goals. So all of these things that we talk about today are done in the context of a shared decision-making situation with families and with patients to come to a common understanding so that they can make the best decisions possible. Again, I'm not going to talk about tone management. Andrea is going to talk about that next. I'm going to talk about lever arm deformity correction, and that's one aspect of these three major problems with cerebral palsy that include tone, contractures, and lever arm deformities. And again, our goal here is to maximize muscle function. Remember that children with different GM-FCS levels have different levels of muscle function capacity. We can't really change that. Cerebral palsy is a permanent, irreversible condition that has no cure. So we have to recognize that we're treating the effects of the condition, and the ultimate level of function for an individual is really going to be dependent upon the severity of their neurological injury. So we are just trying to help them maximize their potential muscle function that they have. And we do that by managing the tone, managing these bone and joint deformities. That allows our therapists and our children and families to be able to be active, to participate and have recreational activities to strengthen muscles. And then we know that for many children, they will have residual deficits in muscle function that mean that we need to use orthoses or assisted devices. And again, all of this is meant to help them maximize their functional capacity. I wanted to spend just a little bit of time talking about something called the plantar flexion knee extension couple. I think we know that the plantar flexors are named plantar flexors because they have a plantar flexor function. But in upright gait, if the soleus is working properly, it controls the position of the ground reaction force so that actually that internal reaction to the external force is anterior to the knee joint center. And if that's the case, there's a secondary coupling effect that leads to extension of the knee. So let's look at a couple of animations to understand this better. So this animation is walking along, and we're going to focus on this point in the gait cycle when they're in mid stance and see what happens. In the first case, if we increase the activation of the ankle plantar flexors. Increase it here, and you see that the heel rises and the knee extends. So that's all a function of the ankle plantar flexors. In this animation, the electrical activation of that muscle is decreased, and when that happens, the ankle collapses into dorsiflexion and the knee collapses into flexion. So we think about that plantar flexion knee extension couple, and I will come back to that several times here along the course of the way through the course of this discussion. So let's come back to this lever arm issue and lever arm dysfunction. So if I say lever arm dysfunction, what I mean is that that lever arm portion of the moment is abnormal. So the skeletal alignment that the muscles are able to work on is somehow not correct. And there are several different types, and I'm not going to be able to spend time on all of these, but I will focus on foot deformity and malrotations, including tibial torsion and femoral anteversion, and look at what happens to the desired primary moment and undesired moments that come into place. And the easiest example is to think about foot progression angle and the function of the ankle plantar flexors in light of that plantar flexion knee extension couple that I was just talking about. So if the foot is properly aligned, as a person is walking forward, the ankle plantar flexors have a nice long lever arm to be able to work on this D distance here. And that D distance is all directly in the line of progression so that the flexion extension moment is maximized and we don't introduce any unwanted moments in the other planes. If you have an abnormal foot progression angle, and in this case, it's external. So now in this case, maybe related to an external tibial torsion, now this force is working on a shorter lever arm so that the desired moment in the line of progression is diminished. And now we're introducing these moments in these other directions, both in the coronal plane and in the transverse plane. And hopefully that makes sense to you. And it's a big reason why we do surgeries to correct foot deformity and tibial torsional abnormalities. So if I talk about orthopedic surgery today, I'm going to talk mainly about fixing these levers. So let's talk first about excessive femoral aneversion. It's a pretty common problem. The problem with excessive aneversion is that it can abnormally affect the hip abductor moment arm. So if you think about single leg stance, the body weight is working around the hip joint and would cause the hip to collapse into adduction and would lead to pelvic drop. And in order to avoid that, we use our hip abductors on the opposite side to provide for that balance. And the hip abductors have a very big job to do in order to counteract this body weight support that's actually working on a longer lever arm. So if we think about a diagram, we're thinking about something like this. And the problem is that if you have femoral aneversion and you're walking with your lever arm in this position instead of directly in the coronal plane, the coronal plane moment that you generate is smaller because this lever arm distance is shorter and you're creating some of these unwanted moments. Now it gets even more complicated than that because some children will walk with some quote unquote compensatory internal rotation of various degrees. And the more they do that, the more they actually correct and compensate for that femoral torsion so that their hip abductor moment arm is restored. So that seems like good news, right? But in this case, you've got a foot progression angle that's normal, so that's good. And you don't have any in-toeing, so that's good. But again, you have this weakness of the hip abductor moment arm. In this bottom case, the patient is in-toeing and tripping and falling, but their hip abductor moment is better preserved. So you've got all sorts of different scenarios, and we see all of these different patterns. So you can ask yourself, why should we fix the femoral aneversion? So in this first case, if they are compensated and they've corrected their lever arm at their hip, their hip lever arm is fine, but they could be tripping and falling doing the in-toeing. And in the other case, where they're not in-toeing, their hip abductor moment is impaired, so they have more of a Trendelenburg gait. So these are the reasons that we need to think about this complex issue of femoral aneversion and how much to correct and when to correct it. How do we decide? Well, I think most of us here on this call know that you do a physical examination. This is done in the prone position. You palpate the greater trochanter. In some of our patients, the amount of internal femoral aneversion is really quite severe. So in this case, as we're palpating, we palpate the greater trochanter. The tibia is in perpendicular alignment relative to the femoral condyles, and that's the way that we measure femoral aneversion by physical examination. And in this particular case, it's even more severe than this 25-degree angle. It's actually as much as 60 degrees, really quite severe, many standard deviations away from normal. We get a lot of data from the Gait Analysis Laboratory about femoral aneversion. From an observational standpoint, this is what you oftentimes see. You see a picture like this that you might say is scissoring, or you might think it's a valgus knee, because that's what it looks like. But the problem with this visual observation is that scissoring in the past has led to an awful lot of excessive adductor lengthening surgery. And a valgus knee deformity is a very different animal than malrotation and flexion. Because if you do the gait analysis, you actually see that what's going on is that this child is walking with excessive knee flexion, shown by this graph, and an abnormally internally rotated hip, as shown by this graph. So if you don't have the gait analysis laboratory, you could be misled to treating the wrong, what you think is going on, but it's actually the wrong problem, and you're not treating the right issue. Now, in addition to gait analysis, there's a relatively new X-ray technique called EOS. EOS is very low dose radiation, simultaneous biplanar X-ray. So this is a case example after a femur derotation that I did distally for this patient. So you can see the implants that are in place. But by doing these simultaneous images, you can stitch them together using a 3D musculoskeletal model to create a true 3D picture of the skeletal structure in many different planes. And with that, you can get a group of measurements, and I'm going to focus on this group of measurements here at the bottom, because in our children with cerebral palsy, these problems with femoral torsion and tibial torsion are very common. So it gives us a direct readout of how much femoral anteversion there is on each side, and the same thing for tibial torsion. And again, this is done with very low dose radiation. So as opposed to a CT scan, which would be high dose radiation, and of course for any patient, and especially for children, we really want to limit the radiation exposure as much as possible. So this is an added value tool that we put together with our physical examination and gait analysis data to understand the severity of the femoral anteversion, because depending upon how severe it is, it'll determine how often we're doing surgery. So for these mild abnormalities, we virtually never find it necessary to do femur surgery. But as it becomes increasingly severe, we almost always recommend it. And again, these deformities are really quite common in our children with cerebral palsy. Now, I showed you the previous X-ray where the femur was derotated distally. But we do most of these derotations for cerebral palsy patients proximally here in the intertrochanteric area. And in fact, if you're treating just femoral torsion, it doesn't matter whether you do it proximally or distally. It really addresses the lever arm problems. So we get to decide in different cases, depending upon whether there might be a coexisting hip problem or coexisting knee problem, about whether we do at which end of the bone we do it. Regardless of where we do it, it's really important that we have rigid fixation. So most of us use, this is called a blade plate. So the osteotomy is here. This goes inside the femur. The plate is sitting on the surface of the femur and then held there with the 3 screws to provide this rigid fixation, rigid stability that allows early mobilization and rapid healing. I'm going to move on to tibial torsion. I already spent a fair amount of time talking about why we correct tibial torsions, and it's all because of this plantar flexion knee extension couple that we talked about. The problem with tibial torsion is it affects this lever arm. We've already seen this diagram, and we showed you this picture of an external tibial torsion, but in fact, it has the exact same effect if it's external or internal. So internal or external foot progression angles have an equally adverse effect on the ability of the ankle plantar flexors to extend the knee and contribute to upright posture. How do we detect it? Just like femoral anteversion, we have physical exam methods. Probably most or all of you are familiar with this. You can measure the bimalleolar axis angle. You can measure the thigh foot angle. There are more advanced methods that we also use in the Gait lab and in our clinics, called the second toe test. We do get data from the Gait lab as well. So when we do the gait analysis, we do this functional joint model where a patient is standing. We have markers in place on all the body parts. We ask them to do a certain movement pattern at the hip, a flexion extension pattern at the knee, and then we trace the malleoli here with an instrumented wand so that we can get this functional model. This functional joint model gives us a measure of dynamic tibial torsion. So this is a patient's data here in the green compared to the normative data in the gray. And we can measure the offset between the patient's data and the normative amount, and we can say that this is 20 degrees out of plane. And if we go to surgery, we have a surgical technique where we can perform a 20-degree derotation. And this is kind of a cool little video here. So sorry, this is an intraoperative video. Hopefully you're had your cup of coffee and you're not too squeamish yet this morning. So this patient is prone, the foot is up, the knee is down. This is right at the ankle level. Now you can see that a little bit better. So what I'm doing here is I'm drilling holes in the bone that are at that offset angle that we desired, that we detected from the Gait analysis, again, 20 degrees. So we set the goniometer at 20 degrees. We drill these offset holes through the plate. We put pins in and we remeasure. So now you've got that 20-degree measurement. Now it's time to do the osteotomy. So we use the saw. Once the saw is done, you can derotate the tibia. You can put the pins back in place. And then you can turn the pins until they're parallel. And that way you can leave the operating room knowing that you've done this 20-degree correction. It's a very simple and pretty elegant little technique. And it really helps us to do a good job of correcting these tibial torsions. And this is what the x-ray looks like. So again, it's just above the ankle joint. Here's the osteotomy, the metal plate in place with the 4 screws after the fixation. Moving on to the foot. Again, the guiding principle here is the same. We're trying to provide that proper biomechanical position for the foot to function as a proper lever arm to contribute well to that plantar flexion knee extension couple. So all those things that I was just talking about with the tibia are just as true for the foot. So if your foot is inverted and internal or everted and external, it has an adverse effect on the ankle plantar flexors. Our treatments here for the foot have evolved very substantially. As Andrea mentioned, I've been at Gillette since 1991. When I came in 1991, we were doing a certain operation and we pretty quickly moved on because of some new research evidence and presentations that we heard in 1993 to evolve towards a very different paradigm, avoiding these other earlier procedures. One of the other things that's been in evolution is that when we do ankle plantar flexor lengthening, it's almost always just a lengthening of the gastrocnemius and almost never of the soleus. The point here is that the soleus is a very important joint stabilizer, and it's also very sensitive to lengthening. So even if you did a 1 centimeter lengthening of the tendo Achilles, that would lead to a 50% loss in force generating capacity of the ankle plantar flexors. So we almost never do that in ambulatory patients. It's almost always solely a gastrocnemius lengthening, and we've learned that we need to be appropriately conservative in that regard. For the foot osteotomy procedures, one of the most common operations is an oscalcus lengthening. So here's a diagram of the orientation of that osteotomy through the calcaneus in both views. And then in this view, you can see from top down, it's oriented like this. And when we do that osteotomy, we put a spreader into that bone cut so that we can spread it open. And by spreading it open, it rotates the foot around the talonavicular joint to bring this abducted and everted foot back into alignment with the talus and with the ankle. Probably the second most common operation is a first cuneiform plantar flexion osteotomy. So this is an osteotomy through the waist of the first cuneiform. And again, a spreader is inserted to be able to open this dorsally to be able to push the first metatarsal head downward and restore the tripod of the foot. Another fairly common operation is a calcaneal slide. So here we make a cut across the calcaneal tuberosity, and we displace the calcaneal tuberosity medially to correct a valgus hindfoot. So these are realignment surgeries. They're oftentimes done in conjunction with the gastrocnemius lengthening to realign the foot. For more severe cases of deformity or with more severe levels of GMFCS, we'll do fusions. So here's 2 screws across the talonavicular joint to realign this subluxated everted navicular back into the proper position. And in this case, we did it in conjunction with an oscalcus lengthening and a gastrocnemius lengthening. And this is this individual's foot before the surgery. So you can see the planus, you can see the eversion and the eversion here and the collapse of the midfoot into valgus. And those procedures that we did, I just showed on the x-ray, restores the arch, restores the alignment of the foot, and the alignment of the foot and avoiding the eversion. And now with my last few moments, I want to spend a little bit of time on crouch gait because it's so common. The problem with crouch gait is that there are many contributing factors, and it's really hard to work through all of these different contributions to figure out what the right treatment is for your patient. All patients with crouch gait look the same. They have too much knee flexion and stance. And their kinematics also look the same, so that in late swing, they don't extend their knee very well. In mid stance, their knee is too flexed. But it's variable about what's happening with their pelvis, whether it's posterior or anterior, or their ankle is in equinus or an excessive dorsiflexion. So there are many different contributing factors, but in the end, the crouch gait has a knee that's too flexed, which means that this ground reaction force falls posterior to the knee joint center instead of anterior, which means that there's a large increase in appropriate extension moment at the knee. And what that means is that you are using your knee extensors for abnormally during mid stance to try to stabilize your knee to prevent further collapse. And in the end, this leads to an awful large increase in patellofemoral forces and could be a contributor in the long term to patellofemoral pain. Now, with crouch gait, in the past, the hamstrings were implicated in a big way, and there was an awful lot of hamstrings lengthening surgery. And I can tell you that we're doing an awful lot less hamstring surgery to the benefit of our patients. And one of the factors here is that, in fact, for some children who are in crouch, if you measure, and we can actually measure dynamically during gait, the length of the hamstrings, in this case, the hamstrings with an anterior pelvic tilt compared to normal are actually longer than they need to be if you're walking upright. Now, if you're walking with a posterior pelvic tilt, it's actually the opposite. In this case, the hamstrings are shorter than they're supposed to be. And in this case, maybe a hamstring lengthening would be the appropriate thing to do. The fact is that it's at least 2 to 1 that there are more children who walk with anterior pelvic tilt than posterior pelvic tilt, and it's probably even a greater difference than that. So if you're doing hamstrings lengthening for all patients with crouch gait, you're probably inappropriately treating the hamstrings at least 60 to 70% of the time. Now, you can get some hints to this with your physical examination. This is the more traditional method of doing a popliteal angle test, but it misses the boat about the anterior pelvic tilt because it makes it look like the hamstrings have some tightness here. But if you compensate for that anterior pelvic tilt by having the patient flex their hip on the opposite side, you can see that, in fact, the hamstrings are not short at all in this case. And if you'd have done a hamstring lengthening on her, you would have been missing the boat. So the question is if you see patients who are in crouch gait like these two guys, you're not sure whether the hamstrings are short or long, but there's really good evidence from the gait analysis about which is which. So this patient is in crouch. This patient is also in crouch. It's actually worse. You're wondering about the hamstrings, and the place to look is here in late stance. Both patients have a lack of knee extension, but this patient on the left has a pelvis that's going progressively posterior here on the right side, the green. This patient also has poor extension of the knee, but they don't have that abnormal pattern at the hip. And if you measure these musculoskeletal lengths, again, we can do a model to measure the length of the hamstrings. And for the right hamstrings for these two individual patients who are both walking in crouch, compared to the normal, this patient has hamstrings that are too short, and this patient who actually has worse crouch has hamstrings that are perfectly satisfactory in terms of their length. So these two patients would have a very different treatment for their crouch gait, and they did, and they both had an effective outcome. There have been outcome studies that show that if you pay attention to data like this, that the hamstrings do get better when you do appropriate surgery in line with these muscle length graphs. And that if you don't, and you do a hamstring lengthening and there was already an anterior pelvic tilt, that the pelvic tilt can worsen if you do a lengthening. So in summary, for hamstrings, we don't use popliteal angle in isolation. We don't do hamstring surgery for knee flexion contractures, And again, I mentioned before that crouch gait has many possible contributors. So if we're going to think about doing hamstring lengthening surgery, we're going to look at these muscle lengths that we gather from the Gait lab, that we have some inkling of from physical examination, and perform hopefully the correct treatment. So I just want to spend just a little bit of time here in conclusion about older patients with crouch. You detect knee flexion contractures by physical examination. I think everybody here knows how to do that. An extensor lag is a measurement of the active function of the quads. And in this case, the same patient who has no knee flexion contracture has an inability to actively extend their knee fully to their end range of motion. So we call that an extensor lag of 30 degrees. And that's a problem with patella alta and quadriceps function. When we realized this almost 30 years ago, we started to change our treatment paradigm to performing extension osteotomies of the distal femur to obtain full knee extension, and then to move the patella downward. So what do those two surgeries look like? Here's an animation to show you about the extension osteotomy of the femur. We remove this wedge of bone from the distal femur, close that opening down to straighten the knee, and we get a full correction of the knee contracture on the operating room table. When we move the patella downward, we detach its attachment, we put in a stabilizing wire or suture, we pull the patella downward, we create a spot for the tibial tubercle to go, we put the tibial tubercle in there and stabilize it with a screw. From a radiographic standpoint, this is what this looks like prior to surgery with the knee contracture and the high patella, and after the surgery with the osteotomy, the blade plate in place. You can see the knee is now straight, and also the patella is down in a proper corrected position. And when you make these decisions well for your patients, you see effective outcomes. And I can tell you that when I started 30 years ago, we did not have this option. We did not do these treatments, and a patient like this would end up going into their adulthood in a crouch gait. So just this morning, I wanted to share with you one of my favorite pictures from my home. I was realizing as I was giving my dogs a little bone treat that this is one of my favorite boxes in the entire house, and you can understand why. Thank you so much for your time, and I would be happy to entertain any questions that you got. And again, I apologize for the rapid fire pace. Thanks for your time.
Dr. Novacheck, we do have one question here. Since this is growing bone in children, are there certain periods in a child's life where these ortho procedures are done or avoided?
Great
And this
question.
is coming from a
yes,
PT.
I didn't touch. Yep, I didn't touch on that at all, did I? So thanks for bringing that up. The sweet spot for doing orthopedic surgery is somewhere generally, we say, after age 8 and before age 12. And a lot of the reason for that is exactly for the reasons that you asked the question. If you do surgeries at younger ages, there's a significant chance of recurrence. And if you do surgeries later than that, it actually makes it more difficult for the patient and the family and the physical therapist to get through the recovery process. It's longer, slower, a little bit more difficult, and maybe you don't achieve quite as successful an outcome. So the best time for orthopedic interventions is between 8 and 12, depending a little bit, maybe a little difference for boys and girls, depending upon their different ages for skeletal growth.
When should someone consider gait analysis?
Yeah, so typically to do a gait analysis, children, number one, need to be ambulatory. So every now and then we do have a referral to the gait lab and somebody who's in non-ambulatory. So we can, they need to be ambulatory. Secondly, they need to be able to cooperate with a test that takes about 2 to 3 hours to do. Our physical therapists are highly expert at dealing with children, getting them through this test in a very efficient manner, but regardless, it still takes 2 to 2.5 hours to do. So generally the youngest ages are age 4. Every now and then we'll have a child who's 3+, that is very cooperative and gets through the study well. So the youngest age would be age 4. We have traditionally done gait analysis when somebody, whether it's family or provider, is getting highly concerned that things aren't going well. So it's often been done prior to a significant intervention, whether that's tone management or SUMLs. Sometimes children aren't coming in at age 4, they're coming in at age 6 or age 7 when things are starting to become more difficult. And then I mentioned before that after an intervention, we typically want to be able to reassess after the full rehabilitation, which is usually a year after that intervention, whether again it's rhizotomy or orthopedic surgery. We're starting to think about changing that paradigm to be less based on timing of intervention and more based on doing more routine surveillance. So anybody who's working in the Gillette system will start to see that we're going to be planning to do these in a more proactive, more scheduled fashion, maybe like once every 3 years during childhood and once every 5 years during adulthood to detect things a little bit earlier and also to have a better understanding of the natural history of gait in cerebral palsy.
Perfect. I don't know if you can answer this last question in a minute or not, but I will say it. And if we can't get through it all, maybe we'll save this for the panel discussion at 10. But what is the name for the new popliteal angle measurement with the knee if flexion?
Yep, so that is called the bilateral or double popliteal angle test. So if you flex the opposite hip, then you can assess the popliteal angle in that position. That's called the bilateral or double popliteal angle.
Perfect. Is the knee in flexion the evidence-based standard to measure hamstring length?
Well, it can actually be in any position. So when we do the gait analysis, you measure the kinematics. So you measure the pelvic position, the hip motion, and the knee motion. With that information, you can input that into a musculoskeletal model, and that will tell you, it will give you an origin to insertion length of the hamstrings, regardless of pelvic position or knee position. So you can measure that hamstring length from the gait analysis in whatever position the patient is walking in. I hope that answered the question. If it didn't, we can come back to it in the bigger question and answer session later. Thanks, everybody. See you later.